Next, we have to present the Woodfire event, and it's moderated by Professor Michael Staler. Please, Michael.
So, I remember the time when I was sitting there and Chris was standing here. And one thing that he did was he set some rules. And remembering him is not only very personal for me, but I like those rules, actually, so we want to stick to them. Data not given here is considered to be within the limits of normal. All pathological findings are stated. If you want to introduce the patient to a trial, name the trial and its objectives, and of course, the trial has to be open. Don't create a trial for us just to get out of a decision with this patient. If you want to treat a patient with systemic therapy, name only one regimen that you would prescribe and the dose. So not like, I'm going to do a TKI therapy. No. We here as the audience are the patient, and we're going to have a prescription from you in our head. Never put the decision on the patient. Like, oh, let's see what the patient would decide in this situation. But come up with a clear recommendation, assuming the patient will choose the one option you offer. And don't tell me what you could do. Tell me what you would do. And I think we're all going to have a wood fire that looks a little bit like this. We're going to grill our panel just a little bit. And I think we're all going to have a good laugh. Maybe not this guy, because he presented himself with this situation. You have it on your screens. So what you see here is a patient who was otherwise healthy. He had a little bit of asthenia and a little bit of weight loss, about 10 pounds, 5 kilograms, over 3 months. A scan was done with a CT, and that's what you get presented. So for everybody who's not super good at reading scans, this is a caval thrombus up to the heart. You can see the thrombus really deep in the heart. And just let's ask the panel, what would you do? Arnaud?
Sorry, it's okay, yes. I start by a biopsy of the tumor.
Well, why would you do a biopsy? What would that biopsy inform you about?
Because I'm not sure to operate the patient first if it is not RCC. So I would like to be sure that it is CCRCC to decide surgery or not. Anyway, it depends.
What would you do, Tom?
I agree with that. I do a biopsy.
Biopsy? Okay. Alka?
Yeah, I mean, I think the biopsy is needed, but you also need additional staging. Assuming that CAT scan goes all the way, I mean, the chest is fine.
There is nothing.
So, okay.
Okay. Right now? Just like that. Brad?
Yeah, so assuming that the patient doesn't have metastatic disease, I would agree with the biopsy only for the reasons we discussed in my presentation yesterday, which is this patient would progress to a nephrectomy, tumor thrombectomy in the absence of sarcomatoid features found on biopsy. But if I found this was a sarcomatoid variant of any histology, I would actually opt for upfront systemic therapy because the patient won't survive very long after surgery.
All right. He has clear cell carcinoma G2.
Surgery.
Surgery? Alka?
Surgery.
I would consider neoadjuvant systemic therapy.
All right.
With the eventual option, depending on response, to go to surgery.
Surgery for me.
Can I make a point? So just to play devil's advocate.
That's okay.
I don't like that answer because,
Yes.
so Michael told us that there's no adenopathy, there's no metastatic disease, which means this patient has a 50% chance of cure with surgery alone. Assuming that the pathologic finding on the nodes is node negative, then the patient has a decent chance of cure with surgical resection alone. So why not just operate, and if you have adverse pathologic features, then give adjuvant therapy?
Well, I think you can intensify the treatment better by doing neoadjuvant treatment, and potentially it may make the surgery more complete. So those would be the two main reasons.
Do you have some information about the patient, the age, the comorbidity, something like that?
He's healthy. He's really
Very
healthy.
good, okay.
He's a good guy. So there is nothing actual.
I think the main interest to start by a neoadjuvant therapy is to decrease the level of the thrombus and to avoid cardiac surgery. So it could be a good option. And again, if you are looking to the statistician, the overall survival of this patient is at the present time equal to a patient with an intermediate metastatic kidney disease, 70% at 2 years. So it could be really to have an option and to discuss in the MDT to start by a neoadjuvant therapy. But the other option also is to start by surgery because the tumor is not so big, and it seems that it is reasonable to have a good surgery with R0 limits. So really,
I'm not comfortable with neoadjuvant therapy.
You're not comfortable. All right. So we changed the situation a little bit, and you see this little tiny spot here on his lung. Would that change your mind? We have 3-to-1 surgery right away and 1 neoadjuvant surgery. Now, with this one spot in his lung, would that change your mind?
Yes. Because you now have advanced disease, you know you have advanced disease, and you know you've got a systemic problem. And under those circumstances, it's no longer neoadjuvant, it's now frontline metastatic. And heroic surgery in frontline metastatic disease is complicated, and giving len-pen, which you can have a good response rate, is not a bad idea, and I'm not opposed to it. The issue is the data we have for neoadjuvant therapy with thrombus involvement is not that great. It doesn't create these spectacular responses, and it doesn't make patients suddenly operable. And so even now, if you can find a surgeon who says, I can go in, get everything out, and get this out of all the problems, because the whole risk of this approach as it currently stands exists. So I kind of feel that it does change things. It makes the standard treatment for the patient's now got intermediate or porous disease, depending on their classification. But irrespective of that, the presence of advanced disease changes things, and inevitably it's going to need to be more focused on systemic therapy.
Olga?
I feel like the efficacy of our systemic regimens is so much higher now that even with the minimum 50% chance of relapse and of micrometastatic disease, let's say even if you don't see this cell in the lung, I feel like I would optimize systemic therapy with the adjuvant approach.
So, Brian,
I mean, you can see I'm like on the edge of my seat still wanting to operate on this patient. So this patient is likely to be one of those patients that has a 15-month disease-free, progression-free interval after surgery as described in Brian Rennie's study. So I think that, that I would give this patient that benefit of the doubt and eliminate the risk from the tumor thrombus. If you don't, then in addition to giving systemic therapy, you're going to have to anticoagulate the patient, in my opinion, if you're going to leave this tumor thrombus in situ. And you have a risk of tumor thrombus embolism or other horrific events by leaving the tumor thrombus in. So my bias would still be for upfront surgery. And you have a patient with, oligometastatic disease, assuming that that's what that spot in the lung is. And I would be less argumentative about the other approaches in a multidisciplinary discussion, but I would still be pushing for surgery.
And Arno?
Agree with Brad.
Thank you.
Okay, so just to finalize and sum that up, we did the surgery on this patient right away. That was 15 years ago. He's still alive. He's not metastatic. You know, I was surprised that you didn't want to have a biopsy of that lesion in his lung, which was just some fibrosis. It's gone by now. And I was really afraid of this tumor thrombus because it is really narrow in some areas, and you're afraid that he's going to have this embolism. And I haven't seen a lot of patients really responding well to systemic therapy in the thrombus itself. And you see that there's a mechanical issue here. It really hangs in the heart. Even if it shrinks, it will never come down, so it's not going to change the situation. All right, that was an easy one. All right, we have a 55-year-old male. He feels a lump on his chest. It's a little bit to the left side. You can see it here on the topogram. And gets a biopsy from thoracic surgery, and it shows sarcomatoid clear cell kidney cancer. The staging CT reveals a 2.8 centimeter mass in the left kidney and just external metastases. And this is the metastasis here in the sternum, and here's his kidney tumor. Brad, would we take out that tumor?
No. I mean, the patient has metastatic renal cell carcinoma with sarcomatoid features. You might be able to convince me to operate on this patient in a very delayed fashion if the patient does well for an extended period of time on systemic therapy. But this, is a very different scenario from the last one, straightforward surgery but a bad idea, versus a more complex surgery but, in my opinion, a good idea in the last. So I think the sarcomatoid histology changes everything, and I would leave this patient up to my medical oncology colleagues. But, based on the available data, the treatment should be IO or IO-TKI.
Alka, would you help him with a recommendation for systemic therapy?
Yeah. Here, I think it is a clear-cut decision with sarcomatoid kidney cancer, metastatic disease. I think an IO-based regimen makes perfect sense. I prefer the IO-IO combination in sarcomatoid because of the exquisite sensitivity of the tumor to IO therapies. But, VEGF TKI and IO combo is also reasonable.
Arno, would you do the same? Would we do the same in Europe?
Definitely.
Yeah. Tom?
Yeah.
Which therapy?
I think the combination of Ipi-Nivo's got great data in this setting. I think the other combinations have data as well, and indirect comparisons with relatively modest numbers of patients is pretty difficult. You don't need to get immediate control in this patient, I don't think, and therefore giving Ipi-Nivo is reasonable. But if someone came to me and said they want to give Len-Pen, Cabo-Nivo or Axi-Pembro, I wouldn't say it's definitely the wrong thing to do.
So would you do any ablation to the primary?
No. I wouldn't mind. We'd have a discussion about a delayed nephrectomy, maybe 18 months or 2 years in. I wouldn't mind having that discussion. But
All right.
I wouldn't be focusing on that kidney initially.
Andy Wong over there is suffering because he's like, well, why not do something?
Yeah.
So I would say that after IO, or during IO, I would radiate and deal with the primary.
All right. So you want to add radiation therapy? Good idea.
Yeah, especially if it's symptomatic. I would have started the radiation while I was sending them for the systemic therapy.
So we see 4 panelists, 5 opinions.
So
It's kind of good.
In the US, we have a clinical trial called PROBE, which after the first 12 weeks of therapy, if the patient has response or clinical stable disease, you can randomize to nephrectomy or not. So
Yeah.
the deferred nephrectomy approach potentially could be explored here.
So we started him on Ipi-Nivo and did radiation to the kidney and the sternum, actually. And then on Ipi-Nivo, 24 months in, he develops this situation, which is progression in his humerus. So he's still under Ipi-Nivo. The lesion that I can show you, this just look at this real quick here. So it's not unstable, but it's painful for the patient. And this is the result otherwise from Ipi/Nivo, so and the radiation. So there's literally no more metastatic disease in his sternum that you can really measure. There is something left in the kidney that you can still see, but it's way smaller and probably not active. But the disease still is active. What we're going to do now, Tom?
I mean, it's a disaster, isn't it?
It's 25 more months with sarcomatoid
No,
kidney cancer.
I accept you've done well up to now, but this is now. So the patients who I've treated, and I've spoken to a few people, and I've looked at the Kaplan-Meier curves, about 50% of patients go into a durable remission, and essentially they don't need more therapy, and we've got 4 and 5 year data. This is not one of those patients. And those patients that relapse, my experience is VEGF-targeted therapy doesn't do that much. So the reality is you can give them cabozantinib at this point. Whether or not it's going to help very much, I don't know. It's the right thing to do. You can give local radiation therapy again if you wanted to. Again, whether it helps or not, I don't know. But my feeling is that this is going to go wrong quite quickly from here.
Olga?
Yeah. Are you still, is the patient still on the immunotherapy?
He's on
the
immunotherapy 2 years in, yeah.
I think, I've tried doing rebiopsy at this point, trying to look for sequencing to try and get some ideas for targets. But I kind of agree with Tom that with standard therapy, he only has some time of potential remission.
Do I see Mike Atkins in the background there?
Can I ask a quick question while Mike goes to the microphone? I assume he's on just single agent Nivo now.
Yeah.
Would you stop his Nivo or would you just add Cabo?
I would stop his Nivo.
And just add Cabo, okay.
TKI.
You
Mike,
wanted me to come
help
up
us
for a
out.
reason? Should I offer a comment? Yes.
Yeah.
Okay. I would radiate this and give him more Ipi/Nivo. Give him another dose of Ipi and see if we can get a response. Then, if there's no response or more disease develops, then you can talk about your pessimistic options.
So that's a little off-piste, Mike. I'm not necessarily saying it's totally wrong, and I think the story of this is not going to be a good one. So you might say, Tom, well, your plan's a bad one too. But re-challenge with Ipi/Nivo is very unorthodox, and there's not that much data supporting it.
Yeah.
There's no data to support it. We did exactly what Mike did, and it worked for another 2 years. He's actually in a really stable situation right now, and we're good there. I'm not saying this is the right way to do it. It's just, these are rare cases, and it's sometimes you're just lucky and it works. And this is the day, like right now, how it looks. In this.
I think it's important
the zebra, not the horse.
Yeah, I think it's important, if we're going to do that, we need to do some trials around that issue, because I wouldn't want people to walk away from here with the re-challenge Ipi/Nivo as the standard treatment. It's not the standard treatment. And we don't know the contribution of CTLA-4 inhibition in kidney cancer. It's not been clearly defined yet. And we've had that debate over the last 2 or 3 days. And so, in this individual, while you're re-challenging, for every patient that responds, we don't know, there may be 4 or 5 who progress in multiple sites, while we might have got control with second-line VEGF TKI therapy. So I think one needs to be careful about going too far off-piste. Certainly, it's just to put it out there.
I mean, it's a great discussion, but do you really think if you re-challenge him and do early rescans that you're going to lose a lot? Like if you do another scan after 8 weeks to check whether your re-challenge would help him or not?
Yeah, I mean, you just need a bone metastasis to appear in the spine, to grow quickly, cause problems, can't walk, new pain, new problem, new pelvic disease. For every patient, that we can show that goes well, I can show 4 or 5 that doesn't work, and it's important that when we describe these cases, they're balanced, and the principle that immune therapy works forever in all patients is not true, and the principle of re-challenge with immunotherapy or the most recent trial we've just done, CONTACT-03, we're going to see the results fairly soon, but it's negative. So I think the principle of re-challenge with immune therapy is one that we should be steering away from, not towards, in my opinion, until we see some data to support that.
Yeah. So, Tom, are you saying you've done this multiple times and it didn't work?
No, but I haven't seen I haven't seen people who have done it multiple times, and I'm very happy if someone can come up with a retrospective case series of sarcomatoid renal cancer where re-challenge with ipi/nivo is associated with a 60% response rate. I'll be the first person to put my hand up. Yeah. But I was just chatting to someone. This is a case. I was chatting to someone 15 minutes ago. Genuinely, 2 sarcomatoid renal cancer patients. He stopped the VEGF-targeted therapy. He stopped the immune therapy. The cancer came back. And I've got a case where we didn't stop the therapy. We did stop the therapy, and it didn't come back. And so we've got lots of anecdotal cases around this, and this is perhaps somewhere we should be generating data. But I am anxious about going a long way off-piste with no data. And yeah, Mike, if you can show me 10 cases where you've re-challenged and you've generated 2 years response, I'm all over it. I'm up for it. But otherwise, I think we have to stick to the guidelines a little bit. Otherwise, we're in a wild world out there. And CONTACT-3 doesn't help us. CONTACT-3, re-challenge. Let's look at the data when it comes out. But if this re-challenge with immune therapy, and some of those patients will be sarcomatoid, I guess, we just need to be careful about when we jump on board with going so far off-piste. It's so far off-piste.
Just to say that CONTACT-3 does not give the patient the thing that they responded to in the beginning and that they're no longer getting.
And I think that data will need to be taken in the wider context of, NTIVO and whatever. I think it is NTIVO with nivolumab and tivozanib.
Yeah, just 2 points. One, these high humoral lesions that are painful like this, these are really, really symptomatic and hard to control. So I would recommend surgery on a case like this because you can already see some of the bone, some of the cortical destruction going on. It's all the way across that head there. So that's one point. And then the second point is that we actually have a clinical trial in the U.S. for this as well, which is the Raina McKay's Alliance trial of Radical, which is cabozantinib plus or minus radium. And there's, it's obviously got a lytic kind of soft tissue component to it, but it's got a blastic reaction to it as well. And if you look at that sternal lesion, there was a lot of blastic activity there. So we don't really know what the activity would be. There's been one phase 2 study of radium in refractory renal cell to bone that did have some results. And I think it's an important question we answer for this subtype of patients. So that would be, especially if there are other lesions visible on bone scan or on bone survey. So one other thing to think about.
All right. Awesome discussion. June 2008, partial nephrectomy, PT1A, G1, clear cell RCC, 2012, 2016, 2018, resection of lung metastases. And now we are in April 2021, asymptomatic liver, lung, peritoneal, and local recurrences, and symptomatic in the thoracic bones, TH4 and 7, and in the pelvis. And here's the MRI of the spine, so there are lesions all over, as you can see. And this is how the lung looks of this patient. You see those lung lesions here, antisurgical scarring. It's clearly progressive disease. We do see here the liver metastases, some of the peritoneal lesions in the lymph nodes that we can address here, and the local recurrence on the left side. And here are the labs of this patient, so there's not a lot going on. He has a little bit of anemia, and this turns this patient into an IMDZ intermediate risk patient. How we're going to move on now? Let's start with Alcon.
I'm assuming the last biopsies have every time, or resections have shown clear
Every
cell,
time it
clear cell.
was the same clear cell. Yeah.
I think frontline IO-based regimen that I would favor a VEGF-TKI and IO combination in this patient with the extent of disease.
We had those rules in the beginning.
So you want
So
you
which
want the
one
name
is
and the
it?
doses, sorry. Okay, so cabozantinib 40 milligram daily with nivolumab.
All right,
Once
Tom,
a month.
would you do the same?
Yeah, I mean,
You probably have a trial for this guy.
so I'm not going to go into, there are studies for this individual, but I won't necessarily talk about those. There's a len-pen trial versus 2 triplets, which I think is worthwhile recruiting to. But the reality is that this is slightly unusual because the history is a bit unusual in that they've gone from what I think is really indolent good risk disease, which is going to be, I suspect, super VEGF driven, into what now looks like a dynamic change and the disease is behaving differently. I suspect they're going to have a strong VEGF component to it because of the history of the isolated relapses, but clearly a clone has mutated or changed, and Samra's done a lot of work on that, and I don't know if she's here, but I'd be really interested to hear what she thinks. But there has been a change. I also, would be very happy with a VEGF TKI IO. Pick one, use it well. I don't mind which one you want to use. And I'd give len-pen because in the NHS that's the only one we're allowed to use. But if you came to me and said I'm giving ipi-nivo, I wouldn't say it's definitely the wrong thing to do. The one issue with that is, as I said before, I think there's going to be a VEGF component to this, although I don't know that, but that's how it's behaving, number one. And number two is those bone metastases, I'm quite keen to get in control of the disease. So I'm giving len-pen because that's the one I'm giving in the UK.
Would you do radiation to the bone lesions?
No.
You would wait until the effect of the systemic therapy would weigh in?
Yeah, I'd do a scan at 12 weeks and see where we are.
All right.
But again, yes, it's an evolution which is not usual, to have, I imagine that he had the first resection were done for solitary metastasis, I imagine, and I think I think we really have to be sure that it is a kidney cancer. So probably if a biopsy of metastasis is not so difficult, I think it will be not a bad idea to start by just biopsy to be sure that this is the clear cell.
I'm okay with that. I just kind of, I like doing tests and stuff, but we have to, if you're in an environment where you can get tests and the result the next day, that's great. But if you're in an environment where it takes a couple of weeks to get a bone biopsy and it takes 2 weeks to get the histopathology result, I wouldn't want to sit on this for a month waiting for that biopsy result. This is a patient who's in harm's way, and I'm really keen to get in control. And I would even start therapy without a biopsy and maybe do a biopsy if I didn't see exactly what I was expecting. But I agree with what you said. In an ideal world, we'd always have all the information. But sometimes we have to do things without all the information. And I think this would be a case where I'd be relatively comfortable. They've had multiple biopsies in the past. They've always shown clear cell. I agree there's been a change, but I wouldn't want to wait a month or 6 weeks before getting that result. If I had it in front of me the next day, terrific.
I think the liver lesions do make you get a sense of urgency here to treat. And, that's not captured typically in the IMDC criteria. So I think it is reasonable to start treatment. It's not wrong to biopsy, of course.
I think you're right. This is nasty disease. This is something different than actually just the pure data are showing here. And it's probably something worth thinking about. All right, great. So we have a 55-year-old lady, mother of 2 children. She has asthenia and back pain, just Crohn's disease, without therapy for the last 8 years, was well controlled. And with the back pain, she gets staging, and that's what we see here. Lung is clear. This is a tumor on the left kidney. Doesn't look nice to anyone. And it's a little bit like the thrombus. Labs are all normal. Nothing there that can hint us towards anything. She's symptomatic from the tumor because she has pain. Now, maybe we start with Arnaud.
Yes. So it looks like a clear cell, but again, we are not sure about that. It could be certainly an aggressive tumor. Again, as I said, if you're looking to the literature, the percentage of the 2 years survival for this patient is 70% at 2 years, and with the same that patients with intermediate IMDC metastatic patients. So I do think that obviously the surgery is possible, but with probably splenectomy. I'm not sure that the mesocolon is not invited. So again, the surgery is possible, but because of the drug that we have today, it's possible to start by systemic therapy. The problem of this patient is that she has a Crohn's disease. And I do think that the oncologists are not very happy with this sort of disease. So if a treatment by a combination IO-IO or IO-TKI is not possible according to the syndrome of Crohn, obviously we have to start by surgery after a biopsy first. But if the oncologists are okay to start by treatment, I think it's better to start by biopsy first, a systemic therapy second line and second intention, and surgery after the decreasing of the tumor.
So Brad.
Yeah, I wouldn't biopsy this. She's symptomatic. I would take her to the operating room and I would do a nephrectomy and lymph node dissection.
All right. Tom, now the patient shows up with you and she's like, oh, these terrible surgeons, they want to take out that tumor and I'm not sure it's the right thing to do. I really want to keep my kidney. What should I do?
I think keeping the kidney would be a mistake, and I think they should have an operation relatively soon.
So would you otherwise, so Brad is offering her a nephrectomy, Arnaud is offering her a nephrectomy, and you're like, but she doesn't want to have a nephrectomy. Would you do neoadjuvant
I don't want to get an
therapy for her?
EasyJet flight home this evening. I think that there needs to be I think going through this neoadjuvant approach and taking risks is the wrong thing to do. And I think that I'd explore why she doesn't want to have a nephrectomy. Because it's a bad decision not having surgery right now. And in life, you need some guidance. And right now, this is a big, nasty tumour, and you've got a couple of surgeons who can go in and say they can do a good operation. And I think that's what she should have. If the surgical team come back and say, I can't do a good operation, there's going to be stuff left behind, there's going to be problems here and problems there. If she won't sign a consent form to have an operation, then that's a discussion for a different day. But I think offering patients alternatives off the standard therapy, which are unproven and potentially unhelpful, actually just confuses patients. So it would need to be, no, I'm not going to sign a consent form to have an operation, what's option B? And then they'd have to come back and have that discussion there. But I'd be pushing them down a surgical route.
Can I ask an additional question?
Yeah, sure.
Does her face look normal?
Yes.
Do her
it
lungs
does.
look normal?
She totally is normal. There's
Okay, I mean,
nothing.
I wouldn't argue if she said, can you do a partial, with saying maybe, but it's a bad idea. I mean, it looks like it's potentially partialable, but I think she should have a radical nephrectomy.
Yeah. Okay.
Do we have the labs? Does she have the regular labs? Okay. Second, to Brad and Arnaud, the fact that we have such a strong circulating collateral veins, does that means that it has slowly been growing and more in favor of a clear cell? And lastly, if we had a biopsy and that would say sarcomatoid, what would you do? Although it's not looking like that, what would you do?
Anyway, yes, the presence of sarcomatoid contingency, it's important, obviously, but I think really this surgery, and I'm sure Brad is okay with me, it's a complicated surgery because we don't see exactly, the limits on the pancreas, on the spleen, this collateral distribution. It's not so easy again. So I think really it's not a good option to consider a partial nephrectomy for these patients. It's really not possible. Okay, so she has a very important risk to have metastasis in a few months. So again, I think we really have to propose a treatment which is for me the best option to decrease the mass if it's possible again, and to go to the surgery. If not, obviously we have to make a surgery, but the patient has to know that it's not an easy surgery. I mean.
So the chance this is sarcomatoid, in my opinion, would be almost zero. It would be a world record for the largest sarcomatoid to not have adenopathy or metastatic disease. So I think this is highly unlikely to be sarcomatoid. In fact, I think there's a good chance it's a chromophobe, simply based on the fact that it's a large tumor without significant adenopathy and without metastatic disease. And if this were a clear cell, I would expect that. So that also plays into my thinking that she should just go straight to the operating room. What was your other question?
No, the fact that you have circulating vessels, does that means something about the pace of the growing? I agree with you that it could be a chromophobe.
No, I think those are mechanically driven collaterals, not angiogenic collaterals, if that's what you're asking. Yeah, okay.
So is that you, Rachel?
It's Rachel, yeah.
Yeah.
Hi, has the family history been taken from this patient? I think that's where Brad's going, could this be Birdhog-Dubé?
Yeah, we just sorted that. There's nothing in the family history. There's nothing on the skin. There's no hints towards genetic
Other than 45 years old.
Other than 45 years old, yeah. But there's nothing in there.
But at 45, regardless of what this is, she needs a medical genetics
Yeah, this
evaluation.
patient would qualify
She
for
would, but first you
germline
kind of
testing.
want to have a histology and know what that thing is, right?
Correct.
Okay, so she was taken to the OR at a partial nephrectomy because that tumor really popped out nicely. It was not a big thing to leave it, but she really has nasty histology, PT3A, G4. There was a tiny little lymph node which wasn't seen on imaging, which is not surprising to us looking at that thing. L1V1 R0 clear cell RCC. Now, patient shows up after that with you, Alco. What's the recommendation?
I think you have to delve deeper into the Crohn's disease and how active it is, what has happened in the past. But
As we said, she wasn't on therapy for 8 years because she didn't need to be on therapy for 8 years.
I mean, I think the risks do outweigh the small benefit, especially if the patient truly is no evidence of disease, NED right now, assuming scans have been done after surgery and they're not showing any mets. I would go with close surveillance.
Tom?
Yeah, it's difficult to give someone adjuvant therapy with active Crohn's disease. It's just
It's not active, She hasn't had therapy for 8 years. So she has a history of Crohn's disease,
Okay.
but she doesn't need any therapy for
Well,
it
last
right
colon-
now.
I saw-
She has like 2 or 3 stools every other day, and
she's
that's
had a
it.
normal colonoscopy. She's had a normal colonoscopy recently.
Yes.
Okay, I mean, I think if she hasn't had Crohn's disease for 8 years, I think you could have a go at immune therapy and have a discussion with her. I think under those circumstances, you could have that discussion. Either way, you're going to have a discussion, and that discussion is going to be, look, you've got this therapy. There's a significant reduction in the risk of the cancer coming back. That's about 40%. G4, T3A, 50% mortality associated with this at 5 years, maybe 40%, probably 40%. This is you're significantly in harm's way, but, we could cause an acute flare-up of your Crohn's disease and something could go spectacularly wrong. It's possible. And we might not get back in control with steroids, and that might be catastrophic from a bowel perspective. These patients weren't included in the trial. In advanced disease, with metastatic disease, where you've got to get in control of the cancer, the debate becomes more around giving therapy. I'd be more comfortable giving someone with an 8-year history of Crohn's disease, immune therapy with advanced disease. But in the adjuvant setting, we don't know she needs adjuvant therapy. She may be cured. There's a 50% chance that she will never need it, and therefore there's a 50% chance of putting her in harm's way. If there's been no activity for 8 years and you've got a normal colonoscopy and she's going to the loo once a day, then you'd say, well, actually, we could take that risk if you're up for it. And we'd have to support you very, very carefully. I don't think it's an absolute contraindication, but it may be that favour of giving adjuvant pembro, maybe 70-30, and maybe the Crohn's makes it more 55-45,
You don't seem happy, Brad.
I'm not happy, but I don't have to write the prescription for the pembrolizumab. So, but I think this patient needs adjuvant therapy. I think the likelihood of cure is way less than 50% based on T3 grade 4 N1.
Sorry, N1, you're right. I didn't see that.
So N1 to me, grade 4, And that tumor was what, 14 centimeters?
Yeah.
12 centimeters? Yeah, I mean, this patient has, you know, a very, very low likelihood of long-term cure from surgery alone. And I would rather see her give it a shot and have trouble with her inflammatory bowel disease than have a rapid recurrence and death from renal cell carcinoma. But again, I'm not the one writing the prescription for the pembrolizumab. So.
And I think that's a reasonable position. You know, I think it's totally reasonable to say, look, I think this is probably a good idea to her. But she'd have to say, I agree, I think it's a good idea. Because what you wouldn't want to do is push her down the route, say there's really only one option, you have to have the pembro. Because strictly speaking, if you go into the literature and the trial, they weren't included, we don't really know what's going to happen. And if things did go wrong, and sometimes within adjuvant immune therapy, things do go wrong, and if they do, you're going to have to justify why you did that, and there isn't currently a significant survival advantage associated with that. If there was, it would be obviously more in favour of doing it. And so I think this is there's a fine balance with this, but I don't agree.
In our data set, N1 long-term cure from complete resection of N1 disease in this setting is 5%. So she's got a 95% cancer-specific mortality.
And she's therefore going to be on immune therapy at some point.
Right.
Well,
Yeah.
I would
Right.
argue, though, that the risk really do outweigh the possible benefit. First of all, overall survival, not a slam dunk as yet, and only one study showed benefit with single agent. All the other studies are negative. So with this kind of controversial data, very high risk of immune-related adverse events, and colitis for sure, I would have huge reservations about offering this patient adjuvant therapy.
All right.
So I'd probably have modest reservations, not huge. And I would, they'd have to sign a consent form, and in that consent form, it would have catastrophic side effects written on that consent form. But I think that the point is, at some point, there's a 90% chance of them having immune therapy, and maybe now's better than later.
I think with obvious metastatic disease, the risk-benefit ratio flips a little bit. I mean, it's still, the risk is there, but, it may be somewhat worthwhile.
You're not wrong to be
Whereas
cautious.
Right now, with the controversial data of adjuvant pembro showing or adjuvant immunotherapy showing benefit.
You're not wrong with that.
All right, this patient wants to do everything she wants. She can do. She read about the Ipi/Nivo adjuvant trial, signed up for it, so she went through the consenting and all of that, signed up for it. What you're looking at here is the 4 months CT scan that she got, and you probably didn't really pay attention, and you probably can't see it, but if you do a little bit of playing around with this CT scan, which you can't do on the screens, you see this here, which is like a small thing where the radiologist is, I'm not sure, let's watch it, let's see what we're gonna do. Just to speed up things a little bit, we did an MRI of the liver, and it reveals this like widespread metastatic disease to the liver after 4 months. Now, she was on Ipi/Nivo at that point in time because she had it as an adjuvant therapy, and she was actually treated with it. What would you do next, Olga? Yeah, she is on Ipi/Nivo.
How could she get on
Sorry,
all trials, sort of
but-
exclude patients?
This lesion was the only one, Wayne? I mean, this lesion that we show on the screen.
No, it was, I showed you actually for multiple. So there are like 15 of those lesions.
So liver full of mets.
Liver is full of mets.
This is new, just on the Ipi.
It is
wasn't
on
there at baseline.
Ipi/Nivo while on adjuvant therapy.
I think it's difficult, isn't it? This is obviously it's a disaster. Irrespective of how we've got here, the reality is that pseudoprogression in this disease is quite rare. Multiple liver metastasis is really bad. Pseudoprogression in the liver I've not seen before. I've seen it in lymph nodes. This is going to go wrong. Obviously, if they're essentially only just finished Ipi/Nivo if it's 4 months, because and the Ipi will still be in, so essentially they're progressing on Ipi/Nivo. You would switch to single agent VEGF TKI and see what happens, in my opinion. And I'd be happy with cabozantinib, but if someone said to me they wanted to give axatilimab, I wouldn't say you were wrong.
Yeah, I may do Lenab just to get a rapid response and,
So you would prescribe Lenaf versus cabozantinib?
yes.
All right, so there's no agreement here, which is okay. I mean, there can't be any agreement. We opted for cabozantinib in this patient, and it worked for a pretty long time, actually. I mean, I'm not going to go through the next steps with this patient, all the issues that don't make any sense. All right, maybe another nasty one for you guys. Let's do this guy. So he shows up, he's an oncologic patient, 67, that is him actually. 2006 with a clear cell, nephrectomy, PT1B, G2. 2018, he had a metastatic lesion to his cheek, which was removed surgically by a plastic surgeon. And if you take a close look at his face, you can see there's something happening with that scar. And there might be some tissue that shouldn't be there.
The nose.
I can tell.
So you run an MRI on this guy to see the extent of the disease, and you see this is massive. This is not a small thing. It's covered by skin. The whole cheek is kind of gone. And you need to do something with this gentleman. So, what are you going to do?
So I think he's had a history of slow growing metastatic disease, and this is a local relapse. And I don't think you need to do a biopsy, but some people would do a biopsy, and it's not unreasonable to do that. I don't think it's an emergency. It may be causing some symptoms, but it's not life-threatening, so it's one of those issues where doing a biopsy is reasonable. One would assume the biopsy would show clear cell renal cancer. He's got good risk disease. The management of good risk disease is complicated, as we've all discussed. Single-agent VEGF-TKI was the standard of care. That was superseded about 4 or 5 years ago by VEGF-TKI therapy, with 3 combinations approved. Most recently, the data looks more similar than different from a survival perspective for VEGF-TKI IO, and single-agent VEGF-TKI therapy, and therefore there are a number of options. There's a lack of clarity in this environment. I think most people would say he should start systemic therapy, although there may be people who feel there are local therapies that will be effective. I'm not clear about that, but it would be worthwhile having a discussion, at least with our radiotherapy colleagues. And I would probably give VEGF-TKI IO combinations to start with, and I'd hope for a terrific response. And I would hope to be able to stop the VEGF-TKI at some point.
Which one? We said
well, as I said
we're going to
before,
have a prescription for this guy.
So I pick one and use it well. It's really important, and that's much. I realise this is a game, and I'm very happy to play games, and I'm going to give you one in a minute. But it's much more important about giving these drugs safely, having the right team in place, having the safety net for patients, having a 24-hour hotline, having education and training, having patient forums. These are much more important decisions than one regime versus another. And that's a game that we like to play. The pharmaceutical industry likes to drive us to play those games. But the reality is it's a high-volume team with experience in this environment, because all of the drugs combinations have more similarities than differences. What we learned in the UK many, many years ago with sunitinib and pazopanib experience was we spent all our time debating sunitinib and pazopanib, but when we went into the community, the average number of cycles patients were getting was 2 or 3. Because we weren't teaching people about the best way of giving these therapies. We weren't talking about how to manage transaminitis and how we can get patients through transaminitis. We weren't talking about how you taper steroids and not stopping steroids too soon. So those discussions are much more important than the cabo-nivo versus len-pen debate, which actually is for the birds.
Yeah.
So I'm going to take a very big risk here and argue with Tom that I don't think he should get systemic therapy. He has one metastatic lesion, and every other indicator is that he has indolent disease. So I would absolutely start with a discussion with our radiation oncologist about whether or not this is SBRT candidate.
I agree.
I suspect it is. And if they can deliver SBRT to this, I think he may have a prolonged disease-free interval and probably a pretty good cosmetic result.
I agree, yes.
Alko, you're nodding.
Yeah,
Well-
I agree. I would not go to systemic therapy with the solitary met and such a prolonged indolent disease course. I would look into local therapy to get good control on this. And
So we still have a radiation oncologist in the room, Andy.
Yeah.
Can you do that?
Yeah.
You can treat this, but
Just come to the microphone so that we...
So you can treat this with radiation, but I'm a purist. The oligometastasis paradigm requires systemic therapy and local treatment, like to have the best outcome. If you look at the ones that it started with liver mets from colorectal cancer. Those patients didn't only get liver surgery; they had chemotherapy. They also had radiation. Right? So I'm just saying the true successes if you truly believe this is oligometastasis, then you ought to do both.
Actually, I'm going to completely disagree. See, I gave you a radiation patient, and you're not accepting it and telling me I have to treat the patient with systemic therapy. And you're using a different disease entity to argue your point. So the data is fairly unequivocal that resection of solitary metastatic disease, which, if you don't want to radiate him, I'll send him to a head and neck surgeon instead.
Good luck with the head and neck surgeon whacking all of that out.
If you eliminate his metastatic disease, and he has a solitary met, he's got a 50% chance of long-term cure in the absence of systemic therapy. And we and others have actually shown in that setting with renal cell carcinoma, especially a grade 2 with a prolonged interval from nephrectomy to development of a solitary metastatic lesion, this patient has an excellent chance of long-term survival with just eradication of that spot alone. And the data is fairly unequivocal.
I respectfully disagree. I'm not saying I don't want to treat the patient. I think it's best treated with local therapy, but with some systemic therapy.
And I'm saying that data doesn't exist in this patient.
I think really the goal of the radiotherapy is precisely to avoid to start systemic therapy. So I agree definitely with Brad to say, yes, we start by radiotherapy, and we hope that it will be successful to avoid to start a systemic therapy. Unfortunately, these patients have a great chance to have a systemic therapy, but the later will be the best.
It's quite a lot of local disease there. And, I think systemic therapy will VEGF-TKI combinations will have a dramatic response, and I suspect that will be as good as radiation therapy. I suspect in the end, this is going to be a discussion around the radiation oncologist, but I can see us giving Axi-Pembro, shrinking that down, and then having radiotherapy at the end, and then stopping therapy. Clearly I wouldn't want this patient to continue on axitinib for the next 20 years, and I think we'd all agree on that. But I think that VEGF-TKI would actually have a really good response to that, and probably better than radiotherapy from a pure response perspective, because of what we know about the disease, what we know about good risk responses to the combination. So I think both approaches are reasonable. Maybe it's one of those discussions that one has with the radiation oncologist, and there may be some who are super comfortable doing it, and there may be others which I agree with, which is give VEGF targeted therapy with IO first, and then once you've done your tricks, we'll then try and consolidate with radiation. I think both approaches are reasonable.
All right, so he started on systemic therapy. Didn't really work that well, and I'm just going to run you quickly through this. This is on the left side. This is first systemic therapy.
What was it?
It was sunitinib because he was from Russia, and that was the only thing he had access to. And it's good risk patient, and you have a treatment pause there. Didn't work. And you're ending up with this situation in here. We then switched him to cabozantinib, and that caused this situation to this gentleman's face. And lenvatinib and everolimus left him with this here. And he finally got his radiation therapy that we thought he should get in the first place for this situation. And that was the result that he ended in with. The problem was that he finally died from local complications because that tumor in the depth found a way into the vessels and he bled to death from that lesion. So it's really unfortunate.
Yeah.
And I'm not saying we did anything right or wrong here or whatever. It's just we were facing these situations with patients where whatever you decide is not going to work.
He didn't have immune therapy.
Yeah.
He did not have immune therapy, and actually he did not have immune therapy because there's something going on down there where he's from. It's called a war, and it was simply not possible to treat him anymore.
Did he have any disease anyplace else throughout this, or was
No,
this-
he did not.
So I'm
He
still
didn't.
going to argue that if he had
Yeah.
local therapy at the outset, that he would have been okay.
Do you take the advice of a plastic surgeon, you mean?
So
Before,
going
obviously,
back,
before
that
the
wasn't
evolution-
that was not an oncologic resection. I think that was one of the biggest issues that he faced. He had some plastic surgeon take that out, and they are like, oh my God, that's cancer. And I think he would have been better off seeing somebody who knew what he was doing in this situation. And
I
that's,
agree. These indolent diseases typically don't get a good response to systemic therapies, I feel. And upfront surgery or radiation is probably better.
all right. I think we're going to do quick cases, real quick, one for the surgeons, one for the oncologists. So we have a 40-year-old female. She got a birthday present and was a checkup with her GP, and the GP saw something like that on her kidney. So you see a big tumor on the upper pole, and it's actually not a nice birthday present. I don't know who gave that to her. This is the actual CT scan here that she has, just to complete that. So then you get a little bit of an impression. I'm going to, it's not running, to give you the size here. So we have a 9 by 9 centimeter tumor on the upper pole of the left kidney. I know. 40 years old, big tumor.
Obviously, the chest is okay, the lab is
Everything
okay,
is
everything
fine.
is okay.
As I said, whatever I don't mention is normal.
Obviously, surgery. I hesitate between partial or total nephrectomy, but according to the results of the Mayo Clinic and the Brad Leibovich publications, recent publication, I do not think that if the renal function is okay, I think probably we can propose a total nephrectomy for this patient, and because the part would be keeping in after the surgery, just the low part will be very small, and I'm not sure this very small part of parenchyma will be really active, you know. In the case you presented just before, we see that the part after the partial nephrectomy was very small, and I'm not sure it's really efficient. So for this patient, I will propose a total nephrectomy. Obviously, we can do you can do a biopsy, obviously, but I think we really have to consider our radiologist. And you know, the description of radiology is important, obviously. So it could be an oncocytoma.
Probably kidney cancer, as they always do. You know, their histologic capabilities are really limited in radiology. I don't know why, but they don't never tell us really what's going on. Tom, would you do a biopsy? You're a voice of reason.
I mean, I think it's so clear-cut you probably don't need to do a biopsy. I think there's certainly a vogue to do that where we work, and there's no specific reason, there's no contraindication to doing a biopsy. And if you have that facility at your centre and it's routine and it's standard, you can do it. But I don't think with this lesion you have to do a biopsy. Clearly there's something very wrong here.
Brett, you published that paper. You want to comment on it?
On biopsy?
No,
Yeah.
not on biopsy, but on what to do with this patient.
I'll start with the question about a biopsy. I don't know how a biopsy would change the approach to a patient with a large localized mass. there's nothing inherently dangerous or wrong with doing a biopsy of the lungs, but I just can't imagine how it's going to change the outcome of the next step for the patient. And I need to spend a little bit more time studying the images. Can you go back and forth a little bit? No, not that one. Keep going. Go through it one more time. Well, it's partialable. I think the question is, what's the advantage of a partial? And I think, you could leave half or 2/3 of a kidney there. And because she's 40 years old, and because I'm worried that this is a harbinger of a potential genetic syndrome, I might counsel her that her long-term oncologic outcome would be equal with a partial and lean towards doing a partial just because of her age alone. Yeah, that doesn't matter. So the oncologic outcome with complete resection is the same as long as you completely remove the tumor and don't spill it. So the question, if you think it's papillary, is do you do a close partial and try to maximize renal preservation, or do you stay farther away from the tumor? So a papillary tumor is one you don't want to violate the tumor pseudocapsule on. So yeah, I think it will have an impact on your the way you do a partial, but it wouldn't have an impact on the recommendation of a partial versus a radical. And yeah, once you see this intraoperatively, that's going to be a straightforward partial.
Yeah, she got a partial, and it's actually a case I put out on Twitter to some friends to discuss what to do there, just for fun. And it turned actually out that she didn't have cancer, but an oncocytoma.
Yes, you see.
Therefore, I think not taking her kidney was beneficial to the patient in this situation. But I agree, you wouldn't want to do a biopsy because you would do the surgery anyhow. All right, okay, I promised another one for the oncologists. So we have a partial nephrectomy in 2018 with a clear cell renal cell carcinoma of a PT1BG2R0, it's more than that, 6 centimeters. And in 2022, we see metastases to lung, lymph nodes, adrenal glands, and the brain. And this is the baseline scans here reflecting the disease in the abdomen, and here is the brain lesion. Alka, let's go.
Well, I think we need a biopsy. It's been 4 years, right, since her initial diagnosis?
It's been 4 years. The biopsy will tell you it's a clear cell carcinoma.
Yeah, I mean, I think, and for the brain management, we'd start with neurosurgery evaluation to look at resection in an otherwise healthy patient.
So you would do brain surgery. That is resectable. So technically that is resectable, but the disease, you will delay that systemic therapy for at least 4 weeks.
Yeah,
Would you do that?
I think so. Yeah, absolutely. Take care of the brain first, and then look at, especially with not symptomatic disease, and I would do the brain.
Tom, would you
Address
do the
brain
same?
first.
I'd probably do systemic therapy and stereotactic radiation therapy. I would just kind of give the patient a little bit of systemic therapy first, and I don't, it's widespread disease, lots of burden elsewhere. I'm not sure how much, I'm not sure surgery is going to change the biology or the end game here. And so I'd be doing systemic therapy with, as I said before, a VEGF TKI IO. I wouldn't feel strongly if you wanted to give an IO, and in the UK, Ipi-Nivo and Len-Pen are the two options available to us. I'm assuming this is intermediate risk disease. Is that correct?
It is, yeah.
And I'd be doing stereotactic radiation therapy for the brain. I wouldn't be doing surgery.
So, Len-Pen, Alka, you don't want to treat the patient systemically? You just
I do, yeah, I do. But I would do the surgery, and assuming there's going to be radiation after. But yeah, then I would start the patient on I would imagine either axitinib and pembro.
All right, okay, so we have two different regimens. We started the patient on pembro and lenvatinib as well. We didn't do surgery for that because I'm with Tom there, sorry. Welcome.
That's fine.
I think you delay systemic therapy, and I don't actually see the benefit of that surgery. It's not that easy to go through if you talk to these patients, and we did a lot of surgery on brain mets. And with modern radiosurgery, I do believe actually that you have an as good control locally, and the problem is not the local disease but the systemic disease, and you're not addressing that with the surgery. So
I kind of feel like if you're going to get long-term remission though in these patients, the surgical resection of the brain met matters. Otherwise, I agree that majority are not going to get long-term response when they have brain metastases, but to me, that surgical resection, if you're looking at the long-term potential of getting them into remission, it seems to matter.
Yeah, but so I'm going to give you another chance. I mean, I think that I think that I would argue from a radiation oncologist standpoint that your likelihood of sterilizing this is just as high as surgical resection, right, for a lesion this small.
Another chance, but yes, we do really well with smaller lesions. Hopefully it's not wrong. Surgery is an alternative approach, but in the systemic burden, you get the patient use systemic therapy. I think SRS is the chip shot for us.
Well, 4 years later, the patient has relapsed. So you could have done the scan 2 months later. So the 4 weeks delay to me in the big picture is not. It's a small one.
You can argue that.
I agree. I think it's debatable.
It's fascinating. Radiation oncologists do better with smaller lesions. We as surgeons do better with bigger lesions. We have you in between with all the other ones. So I think in the interest of time, we wanted to finish this meeting in time so that everybody can safely travel home. It was an unbelievably great honor to work with you guys, and I'm really humbled, and this was fantastic. I'm supposed to say a couple of words to close out that meeting. First of all, I want to thank KCA. They did an amazing job putting us to work. They never interfered with any of the scientific program. They really had us work hard, and we could do whatever we wanted. Everybody who spoke here, everyone who was on the faculty, did not only fulfill the expectations that we had, but they were much better than what we expected. I think that this is a platform that brings multidisciplinary teams together where they didn't exist prior, and it strengthens the bonds of our kidney cancer family. And I do believe that we in kidney cancer are family, I said it before, and I do think we should continue to work together as family. Nonetheless, this wouldn't be possible without the support of sponsors. You have a list of all the sponsors. Please take a moment to thank them so that we continue doing this and bringing together battle knowledge for the best of our patients, but because this is a patient organization, and this is what drives us to be better, to get better, to become better, that our patients will live better and longer. I want to thank all of you for your contribution, whether on stage or in the audience, engaging in discussions. And I want to thank everyone who made it possible that we don't see on stage or in the audience, who work behind the scenes did all the organization, sent out all these emails, put the technical necessity to work. And I'm really grateful and honored that I could serve as one of the chairs of the scientific committee of this meeting. Thank you all, and have a wonderful time. See you soon, and safe travels back.